We have three wonderful speakers today who will address the topic of the COVID-19 vaccines, safety and efficacy. You've already briefly heard from Dr. Paul Offit, who serves as the director of the Vaccine Education Center and as a professor at Children's Hospital of Philadelphia, as well as a professor at the University of Pennsylvania Perelman School of Medicine. He is an internationally recognized vaccine expert, infectious disease specialist, author, and speaker. Dr. Christina Masters is a pediatric and adolescent primary care sports medicine specialist at Children's Hospital of Philadelphia. She is also a professor at the University of Pennsylvania Perelman School of Medicine. Dr. Alex McDonald is a sports medicine and family medicine physician at Kaiser Permanente. He is also a social media influencer on #MedTwitter and co-founder of This Is Our Shot, a grassroots movement to increase acceptance of the COVID-19 vaccine. I'm Nicole Keith, current president of the American College of Sports Medicine. Welcome to COVID-19 vaccine adoption and the Black community. Next slide, please. So why this title? When I ask my friends and family members who are Black if they'll take the vaccine when it's available to them, I'm met with a variety of responses. My husband has taken his 2 shots. My mom has taken her 2. I get my first shot tomorrow, and I'm really excited about it. Some others in my family and some of my friends are vaccine hesitant. As important as getting vaccinated is and has been to public health, I do my very best to meet vaccine hesitancy with empathy and not shame. I also try to address, rather than dismiss, history and current events that reflect both the fears and actual experiences of Black people. Henrietta Lacks had her cells stolen in 1951, 2 years after my husband was born, and her famous HeLa cells are still in use today. The Tuskegee syphilis experiment went on for over 30 years. In 1969, the year I was born, the CDC confirmed the need for this research, and the local American Medical Association and National Medical Association supported their conclusions. This study wasn't halted until 1972. My point is, the misuse and mistreatment of Black people for medical reasons isn't ancient history, not to the Black people who are also at most risk for the virus. These events have happened in our lifetime, and if you're still not convinced, they're happening now. My university is reeling over the death of my faculty physician colleague, Dr. Susan Moore, who posted all over social media about the racist treatment she received when she was hospitalized for COVID-19 before the infection killed her, because the doctor didn't feel comfortable giving her narcotics. She was a doctor in the same health system, a single mom of a 19-year-old son, and the primary caregiver for her parents who suffer from dementia. We can't deny that there is implicit bias in healthcare towards Black patients. A recent publication in the New England Journal of Medicine cited a 2016 study that found half of white medical students and residents, open quote, held unfounded beliefs about intrinsic biologic differences between Black people and white people, close quote. The authors of the paper continue, open quote, acceptance of this inequitable treatment as normal is historically rooted in and supported by the beliefs that Black people are intrinsically disease-prone and implicitly or explicitly not deserving of high-quality care, close quote. They compared racism in medicine to racism in policing. The history, current events, fears, and experiences of Black people cannot be dismissed. While vaccine hesitation has been seen across all demographics, we want to focus on Black people today for 3 reasons. First, Black people are being disproportionately infected with COVID-19. Second, those who are infected are disproportionately being hospitalized. And third, those who are infected are disproportionately dying. Black people are 1.1 times more likely to be infected, 2.9 times more likely to be hospitalized, and 1.9 times more likely to die. People have asked me, is this more related to socioeconomic status, access to healthcare, type of job, or type of transportation necessary? I don't know. I really don't know about that. I just know that the death of Black people due to inequities in treatment in healthcare was happening long before COVID-19. And I'd like to spend the next hour learning how we, and all of us can convince Black people that hashtag this is our shot. So next, I'd like to introduce Dr. Paul Offit from Children's Hospital of Philadelphia, who's going to give us updates on the vaccination.
Thank you. Show my screen. That's good. Okay, Nicole, can you see this okay?
Yes.
We're good, great. Okay, so what I want to talk about what we all are hoping happens soon, which is how can we best stop this pandemic? The good news is that if you look over the last few weeks, there's clear evidence that the number of cases per day has decreased, the number of hospitalizations have decreased, and the number of deaths have decreased. So why is that? I think that the answer actually lies at the sort of the top number here, which is the number of coronavirus cases, which you see is about 28 million cases. That's actually number is low. And I'll explain what I mean. The number of cases reported are really those who've been tested and found to be infected. Most people with mild disease or asymptomatic infection have never been tested, and many people who want to be tested have never been tested. So the only way to really answer the question, how many people in the United States have been infected with this virus, is to do something called antibody surveillance studies to see who has antibodies to the virus and who doesn't. Then you can tell who's been exposed. In November 2020, that study found that the reported number of cases was low by a factor of 4. So the actual number of cases in this country is probably closer to 80 to 100 million people, which is at least 25% of the population that's immune. I think we've paid an enormous and ridiculous price for that immunity, which is to say 500,000 people have died to get 25% of the population immune, but 25% of the population is immune from natural infection. Also, we're starting to vaccinate. As of February 13th, about 50 million doses of COVID vaccines have been administered, which is about 15% of the population. Most of those vaccinated have received only 1 dose of vaccine, which provides some protection, but it is a 2-dose vaccine. And you need both doses. About 12 million people have received both those doses, which is about 4% of the population. If you combine the immunity induced by natural infection with that induced by immunization, about at least 35% of the population is probably protected, which is probably enough to start to see a decline in this disease. Plus, we're going to continue to vaccinate. Hopefully, we'll vaccinate at least 1.5 million people per day. If we can get to 3 million people a day, we can stop this pandemic by the summer. Plus, the weather's going to get warmer. So how do we make the vaccine? So this is sort of, if you look at the left-hand portion of the slide, this is a cartoon of the virus. The key part of that virus, as you see, is the spike protein. That's the protein that attaches the virus to cells. So the thinking is if you can prevent the virus from attaching to cells, then you can prevent the virus from infecting cells, or said another way, you can prevent the virus from infecting you. Now, the key part of that virus, the spike protein, is shown on the right-hand portion of this slide. It has the fancy name of receptor binding domain, and that's all the efforts to make a vaccine involve trying to make people develop an antibody response to that part of the spike protein. You can see that the spike protein sort of gives the virus a crown-like appearance, hence the name corona. Okay, so I'm going to focus just on the two vaccines that are out there now, the so-called messenger RNA vaccine. So how do messenger RNA vaccines work? Okay, so messenger RNA is just a small piece of genetic material that we all have in our cells. We have hundreds of thousands of copies of messenger RNA in our cells. What the messenger RNA does is it serves as a blueprint to teach our cells how to make proteins. And we need those proteins in order to survive. Here, what the messenger RNA is coding for is it's coding for the coronavirus spike protein. So unlike sort of typical vaccines where, for example, you might be given the coronavirus spike protein, or you may be given the whole virus or a killed form of the virus or a weakened form of the virus, you're actually given the gene that codes for the spike protein. So your body makes the spike protein. Then your body makes antibodies to the spike protein, which is shown here. The spike protein is actually encapsulated in this little fatty particle called a lipid nanoparticle, which protects the mRNA from being broken down. It's taken up into the cell. It then makes that spike protein, as you can see here. And then what happens is that the cells that take up that make that spike protein then travel to the local lymph node. And sometimes people who get this vaccine will have slight swelling of the lymph node, the glands underneath the arm. And that there it stimulates, it goes to that lymph nodes and it helps stimulate an immune response, primarily an antibody response and also other kinds of immune cells. Okay, so I want to just go through sort of the way these trials were done. So we'll start with Pfizer. The National Institutes of Health put together a group by Francis Collins, who's the head of the NIH, to determine how to do these trials. And the key part of this was the demographics. We wanted this trial, which in this case of Pfizer was like a 44,000 person trial roughly, to look like America. This trial had to look like America. So for example, the percentage of Hispanic and Latinx population was around 26% in this trial. The percentage of Black or African American was around 9.7%. So, and the percentage of older people over 65 was about, in this case, about 20%. So it reflects the America. So when we go to an Hispanic population, we go to a Black population, we go to people who are older, we can say you were in this trial. So you have, so you've been represented in this trial. Regarding safety, the first dose of the vaccine and the second dose of the vaccine are shown here. You can see that as compared to getting a placebo vaccine, which is just salt water, people have pain at the injection site. So it does hurt. There's a little redness and swelling, but it does hurt to get the vaccine. Also with the especially after dose 2, there are other side effects, which include low-grade fever, fatigue, headache, chills, muscle pain, joint pain. That can happen. I mean, it is a sign of your immune system. I mean, your immune system, when it's activated, makes certain proteins that have the fancy name cytokines that cause these kinds of symptoms. So it's just an example of your immune system working. I have a friend actually in North Carolina who volunteered for this Pfizer trial. So he didn't know whether he was going to get the vaccine or whether he was going to get the placebo. He didn't know. Obviously, he was hoping he got the vaccine. After the second dose, he woke up the next day after the dose and he had fatigue and he had low-grade fever. And he turned to his wife and said, "Yes, I got the vaccine." See, that's the right attitude. So we always call these things side effects or adverse effects, but really it's just your immune system working. I have gotten 2 doses of the vaccine. After the second dose, I had about 2 days of fatigue and low-grade fever, which I treated by constant whining. I recommend that. The good news is it doesn't last very long. It really lasts a day or 2 and then it goes away, but it always goes away. And what you're left with is you're left with immunity against a virus that can potentially kill you. In terms of the effectiveness, you can see here, this is a so-called Kaplan-Meier graph, where if you look at the people who got placebo and compare them to the people who got the vaccine, which is on the blue line on the bottom, you can see over time, more and more people start to get disease who are in the placebo group as compared to the vaccine group. And sort of the key number here is there in the center. You can see 162 people in the placebo group got sick, as compared to 8 people in the vaccine group, which was a 95% effective vaccine. That is as good as any pediatric or adult vaccine out there. It is remarkable, actually, that as quickly as this vaccine was made, it was this effective. I don't think anybody would have predicted that, but it's true. Also remarkably, it was as effective in this sort of 95% range for all ages. Didn't matter what your gender was. It didn't matter whether you were Black or white or Hispanic. Everybody had a very high level of protection. And it also didn't matter whether you had any so-called comorbidities like chronic lung disease or chronic heart disease or diabetes or obesity. It worked across all groups. Okay, so let's go to the next vaccine, which is the Moderna mRNA vaccine. So these were basically 2 independent trials, and really one confirmed the other. Is the way it worked. So again, the demographics of the participants are shown here. Again, you want to make sure that the groups represent America. The Black or African American group is about 10%. I think the percentage in America is about 12.7%. So it's very close to what you would expect if you're trying to make this look like our country. Again, in terms of age, you wanted to have a decent representation because although the Food and Drug Administration ultimately will approve this and did approve both these vaccines, it's really the Centers for Disease Control and Prevention that recommends it. And they're not going to recommend it for any group unless it's been shown to work in that group. And again, this was true for a variety of comorbidities as shown here. Again, in terms of safety, there was pain at the injection site. And again, especially with that second dose, there was fatigue, headache, muscle ache, joint pains, chills, low-grade fever in the vaccinated as compared to placebo recipient. And this is why it works so well. It works well because it really activates your immune system. And so you have these side effects, which are transient. They're short-lived, but they're just a sign of your immune system working to ultimately create an immunity so that you won't have to suffer from or be hospitalized by or be killed by this virus. The efficacy is the same story. This is that Kaplan-Meier curve again. You can see that if you got the placebo, you were much, much more likely to get infected than if you got the vaccine, and those numbers are shown here. You can see, if you look at the right-hand portion, there were 185 cases in the placebo group, 11 in the vaccine group, again, for an efficacy of 94%. So these two trials showed that the vaccines were working. They are, although they're both messenger RNA vaccines, they are somewhat different molecules. They're not the same molecule. One is given at a dose of 30 micrograms. A microgram is a millionth of a gram. Another was given at a dose of 100 micrograms. So not exactly the same molecule, yet the result was virtually identical. And it was identical across all sort of age groups as well as all races, and ethnicities. Now, one question that's probably the most common question I get asked is, this is a novel vaccine strategy. We've never used mRNA vaccines to make any other vaccine. So people are worried that because you're giving a small gene, that might somehow affect your genes, meaning your DNA. And that can't happen, and I'm going to explain why. First of all, you have a lot of messenger RNA in the cells of your body, and they live in the cytoplasm. They don't live in the nucleus, which is where your DNA is. In order for the messenger RNA to get into the nucleus, it requires actually something called a nuclear access signal, which is just basically a key to open the lock to allow it to get into the nucleus, which it doesn't have. Therefore, your messenger RNA never enters your nucleus. We can leave the nucleus, but it doesn't come back. Secondly, even if it's there, it's RNA, it's not DNA. It's a different language. It's like, Japanese and Spanish. It would have to, in order to change the DNA, it has to become DNA. In order to become DNA, it has to go through something called reverse transcription, which requires an enzyme called reverse transcriptase, which it doesn't have. Therefore, it can't really ever become DNA. Even if it became DNA, which it can't because it doesn't have that enzyme, it still would have to be integrated into the DNA, which requires another enzyme called integrase, which it also doesn't have. So for those three reasons, it's not possible for mRNA to alter your DNA. It is simply not possible. Your chances of that happening are zero. You have a greater chance of actually becoming Spider-Man after you've gotten a vaccine than you have of it altering your DNA. Although technically, Spider-Man became Spider-Man when he was bitten by a radioactive spider, just so we never sort of get past the science here. Okay, so what are the challenges to stopping the COVID-19 pandemic? What stands in the way? I mean, there's so many good things happening. We have a certain level of population immunity. More and more people are getting vaccinated. The weather's going to get warmer. We have an administration that is mimicking good behavior regarding masking and physical distancing. So all those things are good. What is it, the two things that stand in the way of stopping this pandemic? Number one is the variants. So this is a bat virus. It is a bat coronavirus that came up in China and then started to spread across the world. As it does that, it's going to try and adapt to growth in people. When it does that, it will change. And each of those changes is generally associated with a more contagious form of the virus. That's true. Now, to put these slides are going to look frightening, but let me just explain what they are. Each dot sort of represents a different virus that's been sequenced. If you look in the center of this slide, where it says China to Europe introduction event, D614G, the virus that first circulated in Wuhan is really not the virus that left Wuhan and spread across the world. That was the first variant. and it was called D614G. So actually the virus that is common in the United States, the virus that's common in Europe, the virus that's common in the Middle East is all that D614G strain, which is the first variant. But there are other variants that have come up. There was a variant in the UK now that you can see sort of in the upper right-hand portion of the slide. There's a variant now in South Africa, and there's a variant in Brazil. So this is what happens as the virus gets better and better at adapting to growth in people. The critical questions are not whether you're going to make variants. You're going to make variants. The question is, are they functionally different from that original strain, the original variant? In other words, by functionally different, I mean, are they more contagious? The answer generally is yes. Are they more virulent, meaning more likely to cause severe disease? The answer generally is no. It's never to the virus's advantage to kill you. It needs you. It needs your cells to reproduce itself. So the best viruses, at least from the virus's standpoint, are viruses like common cold viruses, which don't kill you and are easily transmitted. And then the key question here, the critical question that we need to answer is, are these variants more likely to resist the immunity that is either induced by disease or by vaccination? In other words, are people who are either now fully immune or because they've been naturally infected, or fully immune because they've been vaccinated, do those people now, when challenged with one of these variants, do they develop severe disease? Meaning, do they develop hospitalization? Do they go to the ICU? Do they go to the morgue? And the answer is, so far in this world, no. There is no evidence that people who were infected with this D614G strain, or people who were vaccinated basically to prevent the D614G strain, when they confront these variants, and the variants are common in South Africa, common in Brazil, when they're confronted with these variants, there's no evidence that it causes them to have severe disease. It does cause mild disease, sort of low moderate disease, but not the kind of disease that causes you to go to the hospital or to die. That's good. And until that line gets crossed, I think that we can feel comfortable with the vaccine. And so far, nowhere in the world has that line been crossed. And that's all I have to say. So thank you for your attention.
Thank you, Dr. Offit. That was really educational. I have so many questions about the virus and the vaccine, and so it's really wonderful that you were able to answer so many of them in your presentation. We really appreciate it. Next, I'd like to introduce Drs. Tina Master and Alex McDonald. From the Children's Hospital of Philadelphia comes Dr. Masters, and from Kaiser Permanente comes Dr. McDonald.
All right, thank you so much for having us. Can you see my screen? I hope yes.
Yes.
All right, perfect. All right, well, I really wanted to, so first of all, thanks for having us today, and Nicole for putting together this webinar. This is really great stuff. I'm honored to be able to share kind of some of the work that I've been doing in this space with Tina as well. So for those of you who don't know me, I have what's called SMUD, which is social media use disorder. So I probably have a severe case of it. I think Tina probably has a mild to moderate case. So I guess I should put that disclaimer out there right now too. So, you know, what I've sort of done is I've seen so much information out there, and misinformation and disinformation, and really what we wanted to do is create an avenue and to support really not just physicians, but any healthcare hero, right? Whether you're a doctor or a nurse or a respiratory therapist or a physical therapist, or anyone related to the healthcare field, or even just passionate about vaccines and prevention of disease, or if you just want to get back to normal life. I wanted to create an avenue, a platform, a way to help people. So really the goal of our effort, which is primarily a social media effort, is really to elevate the voice of healthcare heroes to build vaccine trust to get to COVID-free world, right? We have a COVID-filled world. We want to get to a COVID-free world, and the vaccine is the most immediate way to get there, right? And to Paul's points before, which is great, by the way, to hear one of the world experts on this. Really, the vaccine is highly effective. It's very safe as well too, and it really works. So our job really is to help encourage people to elevate their voice. And I want to kind of share with you the campaign we've created thus far, so that you can join us, so you can do your part, right? Because really this is our shot, right? It's not about your shot or my shot, it's about our shot. Collectively, everyone needs to work together to do their part. So this is our shot campaign, started with a friend of mine, and we were just talking about stuff, and we're like, we should do something. And I'd done a lot of social media work, and he had done a lot of community grassroots organizing. So we basically combined forces to really spearhead this effort. At this point, we've had over 25,000 healthcare heroes use the hashtag across all the social media platforms. You know, as best as we can tell, we have over 200 million total impressions and total eyeballs that have seen this. So it's definitely a growing momentum, and it's really exciting to see this. So we have a whole bunch of organizations which are involved in this effort, and helping support this. But really, this is truly a grassroots effort, right? Because, you know, we know from information from the Kaiser Family Foundation here, it's not about a doctor, it's about your doctor, right? This is a great looking at age and demographics and political preference, asking people who they trusted surrounding COVID to get good COVID vaccine information. And you can see here at the top of that list is their own doctor or healthcare provider. Now, when we talk about the Black community specifically, you know, these numbers are actually a little bit lower, except for that top line. It's a pretty consistent, right in the mid to high 80s about who people trust about COVID vaccine. For all the other categories there, the Black community was about 10 to 15% lower. And I know, Nicole, you can quote me more specifics on that too. So I think that's really the key here is we all need to speak up. We all need to speak from our own areas of expertise, but also our own personal experiences to reach out to individuals, right? This is not going to happen en masse. We're not going to have someone on the TV screen saying you should get your vaccine. As amazing as Dr. Fauci is, people only trust him 68% of the time, versus their own doctor is in the mid to high 80s. So really our goal here is to elevate everyone's voices, everyone to speak up, to work within their communities, whether that just be your neighbor. When I'm working in the hospital, if I ever hear someone talk about the vaccine, I always kind of pop in and add my 2 cents, right? Because it's about relationships, it's about trust, and we're trying to do that through the digital social media networks at this point, because, you know, we're not doing anything in person anymore this year. So that's really kind of the main thrust and the goal here of this effort. And this is kind of where we sit, right? There's been a huge amount of research and development of this vaccine, which is just incredible in terms of this technology. If you look at the operations of delivery and distribution of the vaccine, there are certainly some challenges, to say the least, right? But that last mile, that last 10% is trust. And that's really where we're trying to focus our efforts. And to Nicole's points before, let's be honest, the medical community has not been the most trustworthy, particularly to our Black community and our Latinx community. And we have some work to do. Quite frankly, you know, the implicit bias that we all get trained within medicine has to be confronted, and that's a big part of our effort here, is thinking about how we reach out to individuals. It's not about one messaging fitting everyone. It's about tailoring the message to each individual, to each patient, to each family member, whoever you may come across. And so that's really the effort here, is because no one can speak to your patient better than you. No one can speak to your colleague better than you. And our job within This Is Our Shot, or our mission, is to help you be a better advocate, to give you tools, to give you resources to really get that effort done. And this is kind of our value proposition, or kind of our strategy map, if you will. We have a movement. We're growing members. We're recruiting members. We're training those members. We're giving them good, accurate information. We're then helping them to engage within their networks, whatever that however small or large that may be, and then we're thinking about the outcomes and what was effective, what wasn't effective, and cycling it back through. Because we're going to be here for a few months at least. Let's be honest, until we can get to herd immunity. And you know, Paul probably knows far better than I do, but we may need to get to the point where we have a booster vaccine, right? We have a annual flu shot, and we may have an annual COVID shot or a biannual COVID shot at some point in the coming months or years. We just don't know yet. So this is not a set it and forget it type of effort here. This is a continually ongoing iterative process. As new information comes out, as people have more questions, it's important that we all keep ourselves up to date, and we can all help continue to answer questions and build trust within our communities. And we have a lot of amazing partners up in the top right here. Dr. Ader Stewart from the American Academy of Family Physicians is an amazing advocate, not only for family physicians, but also for the Black community as well too. So she did a virtual town hall talking about this. Top left here, American Nursing Association put together a really great video regarding nurses and nurses trying to support their members as well, and their community to get to a COVID-free world, right? That's really the goal. So it's really pretty exciting to see where this movement is coming. California Academy of Family Physicians, full disclosure, I'm a member of this group, is doing a lot of work around Black History Month and COVID information and COVID vaccination as well too. So we're really proud to make sure we're strategic in terms of who we're working with and the messages we're getting out. Because again, like I said, it's not a one size fits all, and some communities and some individuals are going to need different information. They're going to need more information to really build trust. Full disclosure, and I apologize for my Philadelphia fans. I'm a Red Sox fan. So when I saw hashtag this is our shot on the jumbotron at Fenway Park, a little bit of me jumped for joy inside too. So it's really a national movement in many respects too. And there's some amazing family physicians and just healthcare heroes from across the nation who are speaking up, who are sharing this information. You notice the Facebook page frame there in the top left of your screen. That's Dr. Mike Sevilla, who is an amazing family doctor from Ohio, and the March for Science actually is one of our strategic partners as well too, and created this this is our shot Facebook frame. So any of you on Facebook, go add this to your Facebook frame. There's one for I will get vaccinated if you're not ready yet, and there's one that I got my COVID vaccine too. So for what it's worth, it's all about normalizing the behavior as well too, which I think it makes it brings it up into the community conscience as well too. Politico just did an article actually about dangerous anti-vaxxer information. And highlighted our campaign within this article. It's one of a multitude of strategies to really try to fight anti-vaxxer information. Let's be honest, there's a lot of information online. There's a lot of misinformation online, and there's a lot of disinformation online, right? Misinformation is, well, we made a mistake, or it wasn't quite fleshed out and we realized that's not correct, right? Disinformation is more malicious and meant to sow fear, right? And I'll be honest here, the anti-vaxxer community is very well funded. They're very well organized, and they're really creating a lot of unnecessary fear. They're manipulating information. They're manipulating quote unquote alternative facts, and it's really damaging our community health. It's people are dying as a result of this, quite frankly. I won't put too fine a point on it. So really, we're not trying to engage the anti-vaxxers directly. We know there's about 20% of the population, more or less, that will never want to be vaccinated, no matter what we do or what we say. And we certainly want to engage them. We certainly want to hear their concerns, but that's not who we're really focusing on. We're focusing on that middle 60% of the population who are vaccine hesitant, who have questions, right? I was vaccine hesitant at first. When I first learned about the vaccine in November, I had some questions. I was worried, but then actually, ironically enough, I attended the advanced team physician online meeting where Dr. Offit spoke, and I had a lot of my questions answered. And I realized, I spoke to some of my colleagues, and I realized this was a very safe, effective vaccine. And when I got the opportunity, I got paged. I was in the middle of rounds in the hospital. I got paged saying you can get your COVID vaccine today. I literally dropped everything I was doing, went and got my COVID vaccine. And I think that's what it takes for all of us to get to the point where we feel comfortable with the vaccine. Within our movement, we're really trying to highlight the racial disparities, right? To Nicole's point earlier, COVID is perpetuating institutional racism. It's perpetuating a lot of inequalities within our healthcare system here, and it's very, very troubling, quite frankly. So we were trying to highlight, we used the Martin Luther King Day to really kind of highlight some of these disparities within the Black community and make sure we try to reach out to individuals in a culturally appropriate and a sensitive way to make sure we don't want to tell them what to do. We want to acknowledge a lot of the institutional harms that the medicine has inflicted along the Black community, but also want to engage them in conversation and work towards building that trust for them as well. We've had some amazing physicians who have spoken up and who have gotten their COVID vaccine. This is Dr. Yancey's pediatrician here in Indiana, who, when I saw this picture with this sign, rebuilding the trust that Tuskegee destroyed, it's really powerful. It's not about, unfortunately, facts and data and numbers are great for scientists, but it doesn't sway public opinion, right? So stories and images like this are what's really gonna change public opinion. Every time I see this, it gives me a little bit of chills, quite frankly. This is an amazing colleague of mine who's pregnant and got the vaccine at 32 weeks, right? And she really wanted to show for her community that she had faith, she had enough trust, she had enough understanding that she would get the vaccine and really lead by example. I think right now we have this unique moment in time where healthcare workers can get the vaccine first, right? Which is not normal. So we can really lead by example. And again, like I said, normalizing this to show your patients, to show your family members that it's safe and that I got my COVID vaccine, and I want you to get yours too, to keep you healthy, to keep your family healthy, to keep your community healthy as well too. So some really powerful images that some amazing healthcare leaders are putting out all around the nation. We also had some fun kind of slightly cheeky information or graphics we put out for Valentine's Day as well, and this is something we'll kind of continue to do just to kind of keep this in the public conscience. Obviously, COVID has taken over so much of our world these days, but at the same time, we need to make sure we kind of we want to keep it positive. We want to stay on the positive side and think about, this is a light at the end of the tunnel. And there's lots of ways we can try to help boost some of this information in these posts and just make it fun and put it into the cultural context. It's not just about, putting it in a silo of science and health and data. It's about kind of bringing it to the mainstream in so many different ways. It's working. That's the bottom line. Since we launched this campaign back at the end of December, we've steadily grown in terms of the number of impressions and eyeballs we've seen across social media. Where last week we averaged 45 million impressions. 45 million people saw the post or something about "this is our shot." So it's really making a difference too. And so I encourage you all to join the team because it's working. We're getting the message out there, which is really exciting in so many different ways. Just more information here about ways we can track this, and these are millions. This is not tens of thousands. It's millions of impressions and tens and thousands of different people speaking up as well. So if you want to join us, go ahead and grab a screenshot of these. You can sign up for email updates. You can join our Facebook group, and then obviously follow along at This Is Our Shot on Twitter, Instagram, and Facebook, and add your own story. Right? This is a grassroots movement. It's not about you. It's not about me. It's about us. And all of us working together to raise our voice and to speak to our communities, right? We're all a member. I'll have family members. We all have professional colleagues. We all have communities, churches, whatever your network is. as a vaccine hero, as a vaccine champion, you have influence, you have ability to speak to those people in a unique way that no one else can. So I encourage everyone who's listening to join the movement, because it's pretty fun too. I'm not going to lie. And then obviously you can email us at info@thisisourshot.us if you have questions or other concerns too. All right, I'll stop there. Tina, I'd love to hear your thoughts too. You do a lot of social media work and are pretty amazing in this space as well.
Thanks, Alex. I think actually what I was going to share a little bit about, I don't have any slides, is a part of my life that maybe a lot of my sports medicine colleagues actually don't realize. They think of me as being really into concussions, which is a little bit weird for some people, but that is sort of what I am into now. But I've only been in sports medicine for 10 years, and that was my midlife crisis career change. Before that, Paul will know that I was an academic general pediatrician at CHOP, where I had the privilege to practice in University City, West Philadelphia, which is primarily a Black community. And I've been in a practice there in primary care for 28 years continuously. And I still am in that practice, even as I have gone on to add sports medicine to my, my toolbox. So vaccines obviously is 100% something that I have lived and breathed and really believed in from the early days where I was an intern resident to when I was the vice program director for the residency program and training residents, giving lectures on immunizations is what they described as being one of the hugest, biggest breakthroughs of the 20th century in terms of what actually has improved the lives of millions. And so it is all about building trust. And just to pick up on a couple of themes that the other three folks have shared here, it is about trust and how do you build trust? You know, it's hard if you haven't built trust over 28 years in a practice with families. How do you do it when you don't have 28 years to do that? And so I think a couple of things come to mind. As I've been taking care of my concussion patients, one thing that I realize is that when they come, the way that you build trust in a more immediate fashion is to really listen. And I think just in the same way that I listen to my patients with concussion and what they're experiencing, our patients who are vaccine hesitant, they want to be heard. And I think being able to treat them with respect and listening to them and listening to their questions and being able to answer is really an element of care. That is why they come to us and not Dr. Google. That there is no replacement for going to your physician and being able to ask a question, have someone listen to you, and have someone give you an answer that is a sign of their respect for you and their care for you. And so I just want to share a quick anecdote from last week, and I'll close with this, that I have a family that I've been taking care of now for probably, I think, 15 years, and because their oldest child is 15, and she has younger kids now. And as she brought her kids in with their first two and the HPV, she was vaccine hesitant and did not want to have her teenagers get that vaccine. And now that her third child is now at that age, we talked about it again. You know, I'm not one of those people to shy away from people who are vaccine hesitant or resistant. It's a conversation we have all the time in pediatrics every day. And she said, you know, that's really interesting. And she'd been hearing a lot about COVID. I think that actually this whole pandemic has been a real educational experience for people. And from that standpoint, she said, what do you think about HPV? I said, obviously, I recommend it. We're giving it younger these days because kids have a more robust immune response when they're younger and they receive it. And her last bottom line question was, what did you do with your own kids, Dr. Master? And I said, well, of course I gave it to them, you know. And so I think, again, all of this, you know, this is our shot. What our opportunity is that we have to do here. It is relational. It is about trust. And I think that we can do it and we can do it together. And I'm really excited that we're all here with us so we can talk about how we can accomplish this.
Thanks, Tina. We are receiving questions, and I encourage those of you who are listening to keep sending your questions in. I'm going to start with a question, and then I'm going to take some of the questions that Lisa is sending me through the chat from the listeners. So my question is there any harm in waiting to see what happens with other people who get vaccinated before getting the vaccine yourself? So I'm hearing this a lot from family members and friends and colleagues. I'm not getting it until I see what happens with everybody else. Is there harm in doing that?
Here's what I would say. I think it is perfectly reasonable to be skeptical of anything you put into your body, including vaccines. this was a novel vaccine strategy. So you could see why people go, you know, something, it's an unusual virus, it's a novel vaccine strategy. Let me just wait to see what the story is. And so you could argue that the trials that were done, the 30,000 person trial of Moderna, the 44,000 person trial of Pfizer, showed that it was effective and showed that it was safe. At least you could say that it didn't have any sort of relatively uncommon serious side effects. But I think one could actually reasonably say, you know what, let me wait till the first 3 million doses are out there to make sure it doesn't have a rare side effect. Well, 55 million doses are out there and it doesn't have a rare side effect. I mean, at this point, you have enough information to say that this vaccine is safe and effective. And a choice not to get it is a choice to take a choice not to get a vaccine is not a risk-free choice. It's just a choice to take a different, and I would argue in this case, much more serious risk. So at this point, I think you're a skeptic, and it's reasonable to be skeptical. I think skepticism should fade away at this point, and because we have enough information. So yeah, the downside is every day you wait to get a vaccine. Now, there's not enough vaccine, so I think we should probably say this more in the summer when there's more vaccine. But if you have an opportunity to get the vaccine, get the vaccine.
I think the other thing too, which should be said is, which can certainly be a downside too, is and granted to Paul's point, we don't have enough vaccine yet, but once we do, the longer everyone waits to get their vaccine, we're giving a lot of these variants more time and more bandwidth to mutate as well, potentially. And obviously that's early information. We don't exactly know where that's going to lead. So the longer we let these sort of mutant strains go and the longer we don't have herd immunity, potentially we're putting ourselves and our communities at greater risk as well too. I'm curious about if some of the experts on this panel would agree with that or have a different take.
Sure. It's another point of that, by the way, is it's the importance of the second dose. I mean, the first dose gives you shorter lived, less complete immunity. It's critical to get that second dose where you get a much higher titer of neutralizing virus killing antibodies, which decreases the chance of creation of these variants. And I think that's getting a little lost here, that because there's such a shortage of vaccines that people are getting one dose and aren't getting their second dose as much as they need to get it.
One of the questions is, are the data showing full immunity after natural exposure?
So here's the way I would answer. There's 3 preprints just came out recently, looking at people who've been naturally infected. I hate the word natural. People who, because it makes it sound like it's good, who've had disease, survived the disease, and now have immunity, who then get 1 dose of vaccine. How do they respond to that dose? They respond as if it's a second dose, and they get a so-called memory response. So I think, and it didn't matter. It didn't matter whether your infection was asymptomatic or mildly symptomatic or severely symptomatic. Everybody had that sort of booster response. So I think natural infection protects. That was always the question when this virus first came out. It's the question for anybody who works on vaccines. You want to make sure natural infection induces protection, at least against relatively severe disease, when you're then re-exposed to the virus. Because if that can happen, then you can mimic the immune response associated with natural infections. That's not true of all infections. I mean, you can get strep throat again and again and again and again. That doesn't then make you immune, which is why it's so hard to make vaccines against diseases like that.
Okay. The next question is, I understand that once you're 2 weeks past the second vaccine, you should still wear a mask for others. However, what should I feel comfortable doing in terms of my personal risk?
Right, so there's 2 ways to look at this. You can look at the altruistic way or the selfish way. The selfish way is if I've gotten a vaccine, I have a 19 out of 20 chance of being protected against disease. That's not 100%. And if you're out and about and you're with people who you don't know whether or not they're immune, which is going to be a lot of people, you can protect yourself by still wearing it. I've gotten 2 doses of this vaccine, and I wear a mask and physically distance when I'm out because I want to make sure I'm not one of that 1 in 20 who are at risk. And then the more altruistic way to look at it is it's not clear whether or not yet whether the vaccines prevent asymptomatic infection where you can still be contagious. My sense of that is it's even people who've been immunized may still be shedding, but I think they probably shed less than people who aren't immunized. But that said, that's a more altruistic way of looking at it. You want to be selfish and go, hey, I mean, I don't care whether I infect somebody else. That's their problem, which pretty much is the way the anti-vaccine people look at it.
So I had this question and it came in from the listeners too, Dr. Offit, when I was listening to your presentation and I heard who participated in the clinical trial, I was surprised that people as young as 16 participated. I was told or heard somewhere, maybe it was on social media and misinformation, that the vaccine was only for adults. So is that not true, or can teenagers get it?
So the Pfizer trial was done down to 16 years of age. That vaccine is approved down to 16 years of age. The Moderna trial down to 18 years of age. What you're going to see now, it's already started, is there are trials that are being done now in children down to 12 years of age. So we'll have those data. We'll have more of those data soon. But the Pfizer vaccine is approved down to 16 years of age. So if you're in one of those high-risk categories, you could, in theory, get that vaccine. There are trials being done now down to 12, and then there'll be trials that'll be done down to 6 years of age. I don't think we're going to go lower than that, likely, but those trials are upcoming.
Thank you. There's a question about the impact of the vaccine on people with autoimmune disease.
Yeah, the CDC didn't distinguish. I mean, the good thing about the mRNA vaccines is that they're safe. I mean, they're not going to cause you to have a worsening autoimmune response. There's no evidence for that. If you're on immunosuppressive drugs, they may be biologicals that suppress your immune system. They may be somewhat less effective, but so the autoimmunity is not a contraindication of getting this vaccine.
Yeah, and I have a colleague as well, actually, who does have an autoimmune disease, is on one of those biologics, and he got his vaccines. And so he kind of tells everyone he can, and he kind of again uses his story and his example to really lead by example too. So to Dr. Offit's point, it's very safe, it's very effective, and we don't know exactly, obviously, in terms of the immunosuppression long-term agents, but it's still very safe.
There's a clarifying question. If you had COVID, would you still recommend getting both doses, or is one dose okay?
That is a great question. And the real answer to that question, I think, is one dose is okay. But that is not the recommendation. Those preprints that just came out showed that if you've been previously infected, if you know you've been infected, if you have antibodies that show you've been exposed to this virus, one dose probably is enough. And especially you can argue now with the limited number of vaccine doses, that would be a reasonable recommendation. It hasn't been made yet. It hasn't. But it's interesting if people who've been infected before, when they get that first dose, have the kind of side effect profile of the second dose. It's what you would expect.
And just to chime in, I'm just like Miss Anecdote today, that basically I got my first shot and then I got COVID and I had to delay my shot by a bit because I was sick and miserably sick with what would be described as a mild case with 10 days of fever, rigor, chills, and it was miserable. But then I got my second dose. I did have a little bit of a booster reaction to the second dose, but I would absolutely say if you've had COVID, get both shots.
And Tina, just to confirm, you probably already had COVID when you got your first shot. It didn't give you COVID.
Correct. Absolutely. No. I know I didn't get COVID. I know I didn't get it from the vaccine. I know where I got it from. I got it from my oldest son coming back from college. So that's how I got COVID. Yeah. So.
Okay, thanks. This is a little bit lighter one, but thank you for some great information and encouragement about addressing vaccine hesitancy. Can't get this song out of my head, but has anyone asked for permission to use Hamilton's "Not Throwing Away My Shot"?
Yes, actually, we have it both through official and unofficial channels. We have yet to hear anything back, although it is my personal mission. If at some point in the next 6 months, Lin-Manuel Miranda does not either like or share or do something surrounding "This Is Our Shot," I will have personally felt like a massive failure. No, I'm just teasing. No, we reached out a few months ago, actually, but I think we should probably do it again now because the exposure we have now has just ballooned so much farther. So if anyone out there listening has any connection to Lin-Manuel Miranda, please hit me up. We need all the help we can get.
To be honest, Alex, it sounds to me like that's the next TikTok challenge.
I like that idea.
Okay, the next question. My husband is a transplant patient. We've had to have special protocols for other vaccines. Can he take the vaccine when offered, or do we need to check with the transplant team?
Check with a transplant team. Yeah,
I have another story there. Oh, go ahead.
I don't know what his regimen is, and so he needs to check with his doctor.
My other personal anecdote on that is that my husband actually is immunosuppressed from a heart transplant, and his transplant team at HUP actually had him get his 2 shots, and he got his shot.
Great.
But there's
That's
different kinds of transplants, like bone marrow transplants. So just talk to the
Yes,
doctor.
exactly. Talk to your doctor.
Next question, do we know how long the vaccine will last?
No, I mean, when those 2 vaccines were approved through emergency use authorization, we knew that they worked for a few months. That's what we knew. That's actually why it wasn't a licensed product. It was really the length of efficacy that kept it from being a licensed product. The safety issue was what you normally go through. And the size of the trials were normal size trials for pediatric and adult vaccine trials. It was the safety, it was the length of time. But again, you're not going to do 3 or 4 year studies to see how long they work when 400,000 people died last year. And you knew that you induced high levels of neutralizing antibodies in the bloodstream, and you knew that you induced the so-called memory cells. So there was every reason to believe it's going to last for a while. I mean, if I had to make a prediction, I would think it would last for a few years. I mean, I would guess it would last for a few years, but we'll see. If it doesn't, you know, we'll certainly know that. And as Alex said, we may need to give a booster shot if there is fading immunity. Another reason for a booster shot would be if these vaccines became resistant to vaccine-induced immunity. But I think it's going to actually last for a few years, actually.
Great, thank you. The next question is, was there enough representation of minorities in the clinical trials to eliminate any hesitancy they may have to getting the vaccine?
Yeah, that's the point I tried to make in my talk. I mean, they were, you know, 9.7%, 10% in those 2 trials is close to the 12.7% in the general population. So, you know, for African Americans, same thing with Latinx, was around 20-25% for, you know, older people. So we tried to make sure that that was done that way, so people wouldn't think they're going to be the first ones to get this vaccine.
Right, and I would just add, to reiterate what I said in my opening remarks, it doesn't matter what science says to some people. There's not a whole lot we can do. We can keep presenting the data. We can, as Alex and Tina do, we can lead by example. We can acknowledge their fears. No matter what, there are still going to be people, no matter what is done, who are going to be hesitant about getting the vaccine. And as Tina said in her remarks, we just have to listen and keep trying. Is there a difference? Oh, go ahead.
So I've had a lot of patients, and I'm sure Tina, you've had the same thing, that, you know, you see these people year after year, and every time you see them, you offer them their flu shot, and they say no, and you give them a little piece of education, and then you see them, you know, 4 or 6 months later, and you offer them their flu shot, and they say no, and you give them a little more education, and literally after some patients, after 3 or 4 years, they finally get their flu shot, and it's all about relationships, it's all about trust building, right? And so, you know, we don't want to tell people what to do. We want to simply educate them and give them our expert opinions, right? When anytime I'm seeing a patient, I always explain to myself, I am your medical guide, right? I'm here to give you information, to make recommendations, but ultimately it's up to you, right? For any Peloton fans out there, it's like Dennis Morton says, I make suggestions and you make decisions. I've started using that with my patients because that's exactly what it is, right? We're here to give you information, to make suggestions. Ultimately, everyone else has autonomy of their own body and can make the decision which is best for them.
Thank you. We are at the top of the hour and there are more questions, but we have to be respectful of everyone's time. So I'm sorry we didn't get to all your questions. I'm very excited that there's so much chatter around this topic and that we had such great turnout. But I want to thank everyone for coming. I'm going to ask the panelists to stick around for just 1 minute after everyone else and after the webinar closes. But thank you, everyone.